Dear professors, dear colleagues, dear guests of the webinar, it's my honor to start our Meet the Expert session number 5. As you know, Meet the Expert sessions are organized within the program of the Master of Sciences in Clinical Mental Health of the Faculty of Medicine of the Aristotle University of Thessaloniki and Professor Konstantinos Fontoullakis as the main supervisor of this program. This program is managed by the World Psychiatric Association 2020-2023 Action Plan Group on Evidence-Based Psychopharmacology, and within the activities of the World Psychiatric Association section on the Evidence-Based Psychiatry. During previous Meet the Expert webinars, we enjoyed the lectures delivered by such prominent speakers as Professor Robin Murray, Peter Falkay, Siegfried Kasper, Richard Lam, Darrell Roger, Heinz Krunze, Roger McIntyre, Dries Musaye. And today's it's a very important topic which is devoted to the problem of suicides and suicidality. We are privileged to introduce our speakers, Professor Rosalba from Harvard Medical School, United States, and Professor Zoltán Rimmer from Semmelweis University in Hungary. But first of all, I would like to give the floor to Professor Afzal Javed, who is the president of the World Psychiatric Association. Professor Afzal Javed, the floor is yours.
Good evening, ladies and gentlemen. Very distinguished speakers and experts. And thank you very much, Daria, for giving a very detailed introduction about the series, Meet the Experts. I must say the whole credit goes to Professor Fontoullakis and his team, because World Psychiatric Association is interested to disseminate and support the spread of scientific knowledge. Although COVID-19 has restricted ourselves, but at least this has given us a new insight how to reach most of the world by sitting in your own homes. And as Daria was mentioning, this is the 5th event in the series, and we were lucky that each series was attended by hundreds of participants. And we do hope that today's topic, which is very relevant, very important, and is going to be discussed and delivered by world experts on this particular topic, will generate more discussions and more interest. I, on my personal behalf and on behalf of WPA, would like to thank the organizers, but more importantly, our honorable speakers for sparing time and giving us their expertise to share their views with others. Thank you very much and all the best.
Thank you very much, Professor Afzal Javed, for your words and support of the webinars and this educational program. And today we will also hear the commentaries from Professor Konstantinos Fontoullakis and from Professor Peter Morozov, who is the General Secretary of the World Psychiatric Association. And now it's my pleasure to give the floor to Professor Eva Maria Tsapakis, who will introduce our first speaker, Professor Rosalba Cervini. The floor is yours.
Thank you, Professor Smirnova. It is a great honor and a delight to be here today to be introducing Professor Rosalba Cervini to the 5th Meet the Expert webinar. Thank you very much to Professor Fontoullakis for organizing this initiative on behalf of WPA and the Aristotle University. Professor Cervini was born to an Italian family in Western Massachusetts. He graduated from Williams College with highest honors in chemistry in 1959. He completed medical education at Johns Hopkins School of Medicine, where he began training in neuroscience with Professor Vernon Mountcastle. He spent a year at NIH with doctors Seymour Ketty, Julius Axelrod, and Erwin Koppin in neuropharmacology, And after graduation, he completed internship at Boston City Hospital in internal medicine, and then returned to the NIMH for additional research, fellowship training in biochemical neuropharmacology. He then returned to Johns Hopkins Hospital for clinical training in psychiatry and was chief resident of the Henry Phipps Psychiatric Clinic there until 1969. He moved to Massachusetts General Hospital in 1969 to help Professor Ketty establish the laboratories for psychiatric research, and he never left. He moved to the Mailman Research Center at McLean in 1977 with the laboratories for psychiatric research, and he became their director after Dr. Ketty's retirement in 1983. In 1988, he was named permanent director of the laboratories, as well as the founding director of the new bipolar and psychotic disorder programs at McLean Hospital, where in 1989, he also became co-director of psychopharmacology and psychopharmacology training. He founded the International Consortium for Mood and Psychotic Disorders Research there in 1995 with colleagues from all over the world. He's internationally known research psychopharmacologist with many contributions to the actions of antipsychotic and mood stabilizing medicines, and has trained over 160 laboratory and clinical investigators. Professor Baldessarini has over 2,200 publications, including chapters on psychopharmacology in Goodman and Gilman's The Pharmacological Basis of Therapeutics textbook for several years, as well as on his own monograph, Chemotherapy in Psychiatry. He has served on editorial boards of leading neuroscience and psychiatric research journals. His seminal work on the applications of lithium in psychiatry spans over 60 years. And if I'm not mistaken, he is the person who introduced lithium to psychiatry first. His recognitions include election to the Scholars of Johns Hopkins University, the Efron Research Prize from the American College of Neuropsychopharmacology, the Falcon Prize for Bipolar Disorders Research of the American National Alliance for Research in Schizophrenia and Depression, the American Foundation for Suicide Prevention Research Prize on Anti-Suicide Effects of Lithium, the first McLean Hospital Cataldo Prize for Mentoring, the Harvard Medical School William Silent Lifetime Achievement Excellence in Mentoring Award, the ISI list of most often cited authors in pharmacology and psychiatry, the Morgan Schuh Award for Lifetime Teaching and Training on Bipolar Disorder for the International Society of Bipolar Disorders, and a Lifetime Achievement Award from the University of Rome. I first met Professor Baldessarini in 1995, when as a final year medical student from London, I applied to join his neuropharmacology labs at the Mailman Research Center in Belmont for the first 5 months of my final year elective period of study. I was involved in place preference experiments testing potential therapeutic molecules. Fatherly, as he was and is, being genuinely interested in his students and collaborators, he adopted me, may I dare say, and I have ever since enjoyed the privilege of a most valuable mentorship experience, among others. In loco parentis, on the other side of the pond, Ross advised me on several career, but also personal decisions. He subsequently accepted me to return to McLean as a fellow during the 2003-2004 school year. Ross is an avid reader with an inquiring mind. He taught himself German to read Krepling from the original. He taught me Areteus from the original too, a humbling but awesome experience for a Greek, among others I had close to him. I last saw him at Cape Cod in the summer of 2017, where I followed his highly acclaimed week-long clinical psychopharmacology overview and recent advances course, which spans for decades, and I strongly recommend. But the floor is to him, and we all look forward to listening to the topic of suicide, update on basic facts. Ross.
Yes,
well, thank you for listening. I'm deeply pleased and honored to be asked to speak today. I am very appreciative to the World Psychiatric Association and to Professor Fontoullakis for the invitation. And I must state in the beginning that I do not consider myself an expert on this topic. I may know a little bit about some parts of psychiatry, but suicide for me has been a kind of a sideline for a relatively short time, and I feel that I'm still very much at the student stage of learning some of the important basics in the field. So that's where I intend to focus my attention today and kind of review some very, very basic information. And I apologize to any real experts who may be listening that this may be a little too basic, but I think it's sometimes useful to have a common starting point for problems of this type. I wanted to begin by making a general point that I think that one of the things that psychiatry has not paid sufficient attention to is that our illnesses, especially the major illnesses, the psychoses and the major mood disorders, are potentially lethal disorders. And we all know about risk of suicide, and that's mainly what I'm going to talk about today, but I want to make the more general point that is illustrated in this classic study from Sweden by Professor Östby, making the point that if you consider, for example, among bipolar disorder patients, their premature death rates, it turns out that if you look at the overall lifetime risk, the number of deaths in excess of usual due to medical illnesses is very, very similar to rates of suicide. In fact, the medical deaths are somewhat higher than suicide. They're about equal to violent forms of death of all kinds, including accidents and homicides and other forms of violence. So the general point is that I think the field has done a lot to investigate suicide and to try to come up with therapeutic interventions that might prevent suicide. We're not doing as well, I think, on the medical side, especially among older patients. The general treatment of the disorders, I believe, helps and can reduce overall mortality. But to focus on death rates and reduce them as a specific therapeutic target, I think is something that needs a lot more attention and work. Now, the next thing I want to turn to is to make a small complaint, and I guess I can do this as an academic. I really don't like the term suicidality. And the reason I don't like it is because it gets in the way of understanding some things that are clinically very important. And suicidality includes an enormously broad range of thoughts and behaviors, starting with suicidal ideation, thoughts about dying or wishing to be dead. And that occurs in a very, very large proportion of the population. And these are recent US data. This is a semi-quantitative Venn diagram, and some 11 million Americans in a year's time acknowledge that they've thought about wishing to die or even ending their lives at some point. About a third of them actually develop specific concrete plans to harm themselves, and about a million and a half will make an attempt to harm themselves with suicidal intent. And if you look at that little black circle in the middle, that's the actual number of suicides. And the point here is that suicides are relatively infrequent out of the whole family of suicidal phenomena. I think one of the more interesting ones for me is we focused a lot recently on the ratio of attempts to suicides, the so-called AS ratio. In the general population, that ratio runs between 30 and 40. So that means you have about 30 to 40 attempts for every fatality in the general population. Now, in the psychiatric population, for example, among folks with mood disorders, that ratio drops below 10. And I've seen numbers as low as 5 in severely ill, depressed, and bipolar disorder patients. And we've been proposing this ratio as an index of lethality. One of the ways it can be useful is that we've found that in addition to reducing rates of attempts and suicides, we've been able to show changes in the ratio of attempt to suicide. For example, treatment with lithium in bipolar disorder raises the attempt to suicide ratio considerably. That is, it seems to reduce lethality as well as having a strong impact on the behaviors. Now, one of the important lessons that we learned, this is a recent study carried out with Professor Tondo, who works in our department part of each year. He runs a mood disorder clinic in Cagliari in Sardinia. And we've put together a huge database looking at risk of suicides and attempts among people with different psychiatric diagnoses. And we've compared men and women. And the usual story is that rates of attempts are somewhat higher, usually in women. Rates of fatality from suicide consistently several times higher in men than in women in most cultures. One notable exception to that rule, I've seen data from People's Republic of China, where particularly in rural areas, there are more suicides among women than among men, largely among impoverished rural populations, and the deaths are usually due to overdoses of agricultural toxins, insecticides and things of that kind. But in most cultures, certainly in Europe and North America, it's much more likely suicide among men than among women. Now, if you look at the list of diagnoses in this graph, bipolar disorder is at the top of the list of major disorders. And even among bipolar patients, there are subgroups that are at particularly high risk. Bipolar patients with psychotic features have very high risk. Mixed features where there's both depression and increased energy and hypomanic or manic features mixed together. This is what I call a combination of misery plus energy. That's high risk for suicide. We find that in bipolar 1, the risk of suicide is a bit higher than in bipolar 2, but they're very similar. And this is one of the things we've been arguing recently, that bipolar disorder, contrary to what many of us were taught in medical school and residency, bipolar 2 is not a lesser disease. It's a different condition, and there are a lot of clinical features that are different. But in terms of disability and fatality risk, bipolar 2 is very bad news. Psychotic disorders such as schizophrenia have elevated risk, but not as high as in the mood disorders. You may be puzzled as to why major depression is at the lower end of this ranking. And the reason for that is that samples of major depression patients include inpatients, outpatients, and everybody in between. So it means there's an enormous range of illness severity. If you look at major depression patients who were sick enough to require hospitalization at some point, then their risks begin to become very close to the risks in bipolar disorder. So again, depression is important, but it depends greatly on severity. And then you'll see at the bottom of the list, the anxiety disorders and obsessive compulsive disorder have much lower risks. Now, this is a recent set of information from the CDC federal data collections that they pull together every year. And for many years, in the United States at least, suicide death by firearm has been the leading cause, particularly among men. Hanging is number 2, poisoning number 3 among men, poisoning is number 2 among women, jumping from heights, car wrecks, that sort of thing are further down the list. Now, the problem with this is that the United States is a peculiar culture, and it's a culture that in which firearms have a very prominent place. We have a very strong gun culture. There's a fascination with firearms that has an enormous political implication and social implications, in addition to interest in target practice and hunting and that sort of things. Firearms have taken on a kind of mystique in the United States, which is not, fortunately, which is not shared in many other countries. In many other countries, hanging and poisoning are much more likely than gunshot. Now, I want to say a little bit about trends that have been going on around the world, and they have, these are some recent data from several countries, and you'll see that many parts of the world have shown or have found lower rates of suicide in more recent years than a decade or 2 decades ago. This is true in many European countries, in China, in Russia, in Japan. It stayed more or less the same. The United States is an outlier. And in the United States, the suicide rate has actually been rising for at least the past 10 to 20 years, with some good news that I saw just recently in the latest federal data showing a small decrease in 2019 data for the first time in 2 decades. I hope that that trend will continue, but in general, for the past decade or so, rates in the United States have been rising steadily every year. And in this slide on the left, you can see what's been happening since the early 2000s. And I can tell you that that number in 2018 went above 14, and in 2019 it came down about a half of a unit of measurement. And the unit of measurement here is the measurement that epidemiologists like to use. It's cases per 100,000 population per year. So again, these are general population data. Now, the data on the right-hand side of this slide, you need to take rather cautiously. They compare what was going on some time ago with what's been happening recently, and you'll see that most of the recent data are larger than in a decade ago. Generally, for the most of the population, risks, as I said before, for suicide higher in men than in women. If this is something that may be true even in juvenile patients, whereas the racial differences seem to shift with age. For example, in general in our population, African American persons have a much lower risk than white Caucasian persons, and similar or a little lower even than in Hispanic people. In our country and in many other countries, native populations, Indians, Eskimos, and so on, have very, very high rates. This probably has a lot to do with disruption of their cultures, particularly by invasion of European immigrants over the past several centuries. But this pattern we found recently holds up in Canada as well as in the United States. Now, very recently, there have been several studies that have come out from the US arguing that the low risk among Black African-American persons may vary with age considerably. That is, that in young adolescents, the risk in Blacks may be slightly greater than among whites, but that's only for very, very young adolescents and prepubertal latency aged kids. So again, this is a complex story. It changes from time to time, but some generalizations seem to hold up. These are some data that I think are particularly provocative because they show that even though generally, at least in the United States, risks in rural areas are much higher than in urban areas, the rates have been rising in urban, suburban, small town, and rural areas steadily over the past decade or so. And similarly among age groups, even though risks differ by age enormously, and among kids, the older adolescents are at much higher risk for suicidal risk than prepubertal children or young adolescents. But in all of these groups, the trends have been toward increases over time. I've already commented on this. I think I'll keep moving ahead. This is a very interesting kind of presentation, and when I first saw data like this, I was really quite shocked because my naive expectation was that I would see more suicide along the East Coast and the West Coast and lower risks in the middle of the country. It's probably not true as a generalization. Our highest risks come in the far west, southwest, intermountain states, and in Alaska. Rates in Alaska are much higher than in the mainland United States, and certainly among native Alaskans, the Inuit population and Indian populations, the rates are sky high. Again, probably as a reflection of the disruption of their cultures in the last century or two. So the generalization seems to be that rurality or being away from the city seems to be an area of higher risk. And we've seen that pattern in other countries as well, and I'll show you some data about that. However, I wanted to remind us again that this story becomes enormously complicated. I just recently saw some data among African American patients, and it turns out that their risk in rural areas is actually lower than it is in cities. And I think among African Americans, city life and urban stresses and other factors that I think are quite well known probably contribute to this kind of difference. But as a generalization, the less densely populated areas seem to have higher risk. These are some new data I just put together a couple of weeks ago when I was doing some teaching in Canada, showing you the same trend, that if you go to less populated parts of Canada, the suicide risk goes way up. And then finally, this is a new set of data that we gathered in Dr. Tondo's research clinic in Sardinia. And there are a number of factors here that are not surprising. I'll say more about risk factors in a moment, but this contrast of rural versus urban risk being 50% higher in underpopulated parts of Sardinia is again supports this general pattern of higher risk with lower population. These are also interesting data that have to do I think in part with the population density phenomenon. These are data that came interestingly from Dr. Tando's Master of Public Health thesis that he did at Harvard about a decade ago. And there's some very interesting findings. These are data based on statewide suicide rates and looking at various factors that differ markedly among states in the US. And one of the striking findings at the top of this chart is that population density, the lower it is, the higher the risk of suicide. Higher among men, very high among Native Americans, much lower among African Americans. And these were all factors thrown in more or less to test the methods, and they seem to fulfill expectations from other studies. So it supports the idea that the methods that Dr. Tanda was using are credible. The interesting things, though, in addition to the population density, the density of physicians, the density of psychiatrists, the density of family income per year are all inversely connected with suicide. So the speculation is that among other factors, probably including access to guns and other factors, poverty and so on, alcohol, many other things, the population density also correlates with the availability or access to care, support, clinical interventions, and so on. And I think that's one of the very important public health views of suicide risk and things that might be done to reduce suicide risk. That is paying more attention to areas of high risk in remote, underpopulated areas, bringing resources and supportive services to those areas probably will make some differences. Now, among other risk factors, probably number one on most lists that I've seen would include previous attempt. Now, many people attempt once or twice and may not do it again, but some people having attempted once may try again, and this is a very strong predictor of eventual fatality. Now, there are other subgroups among attempters who are more complicated. There are people who actually seem to derive benefit from self-injury. These are usually people with personality disorders, not with major psychiatric illnesses, where the cutting or doing other self-abusing behavior seems to have an effect of reducing distress and discomfort. But that's a whole separate topic that we don't have time to get into today. Generally speaking, attempt is an ominous and important risk factor. Major mood disorder is another one. Abusive drugs, particularly polyabuse or abuse of multiple substances, is a very big risk factor. There are all sorts of psychological and social events, losses, deaths, shame, poverty, many other psychosocial factors are important. Social isolation is an important one, and it's very well known that elderly widowed men have much higher risk than in younger men or married men, for example. Lack of access to clinical care, I've already mentioned. Easy access to methods of suicide, particularly firearms, poisons, overdoses of prescribed medicines. All these are risk factors to be attended to. And then one that's become noticeable recently, and I'll show you some of our data on this topic, people who've been psychiatrically hospitalized have a very high risk of suicidal behavior soon after discharge. This is another complicated topic, and let me save it until I show you some data that go along with it. Now, this is a very, to me, a very distressing set of data. It's a summary of literature, basically a review of world literature, led by a trainee in Rome, Alberto Forte, that we put together a few years ago. And it shows you large clinical cohorts followed over long periods of time. These are people who've been ill for an average of 9.5 years, and it shows you risk of long-term morbidity. This is not about suicide. This is about illness. And these are mood disordered patients, so you'd expect to see a lot of depression, and we certainly see that. The shocking thing to me are the green bars, which show you total morbidity over time. And the shocking finding is that among bipolar and unipolar patients, they are clinically unwell 45+% of the time. These are clinically treated people meeting what I think be accepted as community standards for treatment, and even so, they are unwell 45 or more % of the time. That's shocking. Now, in the unipolar patients, it's all about depression. But also in bipolar 1 and bipolar 2 patients, or bipolar patients overall, the blue bars indicate that, again, it's mostly about depression, depression, depression. The red bars indicate that we're doing a pretty good job against mania, and particularly hypomania, but the blue bars are an enormous ongoing problem, and they account for fully 3/4 of the unresolved total morbidity. So I think the short point I'm making here is that bipolar depression, for me, has become an enormously pressing problem. It's not easy to diagnose. How best to treat it continues to be rather controversial and argued about. And I have actually elevated bipolar depression to my hit list of #1 public enemy that we need to do more to understand and to help. Now, these are really very, very ominous findings from another review done with Dr. Forte in Rome, and we went through the world's literature on post-psychiatric hospital risk of suicide attempts and actual suicides. And what you find, if you consider the risk on a per exposure time or % of events per month, it's enormous in the first 1 or 2 months, and then it drops precipitously, and by 6 to 12 months, it's much, much lower. This is a very sensitive bit of information. Even though the data have been collected all over the world, I have a particular concern about what we are doing or not doing in the States. And I think that what this is telling me is that we are not doing a good job of planning for aftercare for patients who've been hospitalized. I think that in the States there's been well, there are a couple of problems. One is it's not easy to get into a psychiatric hospital, and many of the people who get in is basically because of dangerousness, not necessarily because of severity of illness. So people who are out of control, can't take care of themselves, are socially very disruptive, and particularly people who are suicidal or, God forbid, homicidal, are much more likely to get admitted. So this is a particularly high risk group for suicide anyway. And if you don't have a very, very well organized plan for aftercare, have it set up ideally even before the discharge, and have it ready to go the minute after the patient leaves the hospital, then you're running a very high risk. And these data show you that the risk within the first month or two is enormously high. And I think these are risks that we could do more to reduce. it's going to take a different mentality about how we organize services and how we support them financially. But I think, at least in theory, we could be doing a lot better. Now, I think before I run out of time, I want to say a few things about therapeutics. And my bias is toward medically oriented therapeutics, and I acknowledge that there has been a good deal of research in recent years on various forms of psychotherapy to try to reduce suicidal risk. As I read that literature, a lot of it has come out of the treatment of persons with non-psychotic disorders, particularly personality disorders, borderline personality, other neurotic conditions, where the psychotherapies seem to have demonstrable utility, even including reasonably scientifically well-designed trials that look quite encouraging. What about more medical types of treatments? I wanted to show you here a quote from a London physician, not in the recent history, but this is in the 1820s. Dr. Burroughs said that medical treatments for suicide could be considered similar to those that are applicable in ordinary cases of insanity. This is a remarkably prescient insight and prediction of the future. I think in his time, the bad news, there really wasn't much to consider for therapeutics because there really wasn't much to be done except to try to protect people or to put them in a safe place and watch them and try to support them. But there really were no treatments to speak of, and so this was a kind of a theoretical idea. The first treatment of any treatment in the world, medicine, psychotherapy, anything, ECT, the very first treatment that ever got regulatory recognition as being effective was the antipsychotic drug Clozapine, and only in schizophrenia patients. This work goes back to the important study that was led by Herb Meltzer in the States in 2003, where they did a randomized comparison of suicidal behaviors among schizophrenia patients randomized to treatment for at least a year with either Clozapine or olanzapine. And as it turned out, Clozapine looked better. Now, mind you, there were very few actual suicides. And if you look critically at the raw data, there were actually a few more suicides with Clozapine than with olanzapine, but the numbers are so small that I think they don't mean anything. But if you consider interventions aimed at preventing suicide or need to hospitalize someone because of emerging apparent suicidal risk, those kinds of outcomes were strongly favoring Clozapine. Now, recently, yet a third review led by Dr. Forte with me from Rome, and this is a study that is about to appear in the British Journal of Psychopharmacology momentarily. We went through the available world's literature on Clozapine, and that's on the right, and this supports the what I've just said, that Clozapine overall reduced risk considerably and highly significantly. If we look at data on all other modern antipsychotic drugs, olanzapine, aripiprazole, quetiapine, whatever drugs you want to consider, there's nothing apparently going on. And the bottom line is that the odds ratio combined by analytic analysis it runs above 0.9, which means that there's a trivial difference favoring drug against no drug, but it's far, far from significant. So it looks as if Clozapine is something special. Again, not a surprise, and I think the clinical view about Clozapine is, while it's tricky and potentially toxic and dangerous in many ways, it still is a very special medicine clinically and probably does things in the treatment of psychotic illness that no other drug has ever been able to do. The big problem with clozapine for me right now is it needs to be studied more broadly. We have good data for schizophrenia. Clozapine is sometimes used, particularly in bipolar disorder, in cases not responding well to other treatments. But we really need to broaden efforts to look at clozapine in other conditions. And I would think bipolar disorder would be a very plausible target. These are data that I started collecting about a decade ago, again with Professor Tondo from Sardinia, and this is a review of the world's literature on risk of life-threatening suicidal behaviors, attempts, or suicides in persons treated with lithium. Most of these are bipolar disorder patients or people that would be probably considered Kraepelinian manic depressive people, broadly defined, people with recurrent major mood disorders. And if you put all the data together on risks for suicidal events with and without lithium in a mostly bipolar group of patients, if you put all the data together, you get this risk ratio of 4+, which means a 4-fold reduction of risk, highly significant. Now, let me tell you a brief story out of school. When we first saw data like this, it was one time in my life when I became really a little too full of myself. And I thought, this is one time when I'm going to dare send a manuscript to the, by God, New England Journal of Medicine, where psychiatrists usually fear to tread. And we sent the paper to New England Journal. And a month or so later, we got reviews back. And the reviews were fairly benign. There really were no lethal technical criticisms. But the overall reaction was, why should we be interested in this? Who cares? What's this got to do with medicine? Suicide is some kind of a social problem. It's not a medical problem, and get out of here. So we were kind of shocked by that response, and we thought, well, let's try number 2. So we sent the manuscript to JAMA, which is probably arguably the second best or most highly respected medical journal in the country, and same reaction. Got our reviews back, and it was kind of a big yawn of why should we be interested in this? Well, the thing that was shocking to us, this is a 4-fold reduction of risk. This is a dramatic effect. If we had sent a paper to the New England Journal saying that we reduced risk of cancer, heart attack, by 5 or 10%, that would have been above the fold in the New York Times the next day. But this was somehow received with a very strange sociological set of attitudes about psychiatry, about suicide, that it's something other than from general medicine. And again, I know I'm becoming a little preachy about this, but it bothers me. And I think that I hope that this kind of attitude doesn't obtain in other parts of the world. And indeed, we sent the data to a leading European journal back a decade ago, and they accepted it immediately and saw the importance of it. Anyway, we tried very hard. Fred Goodwin and I prepared what's called a citizens petition to the FDA soon after this paper was published. And we cited all this evidence to the FDA and said, would you consider recognizing lithium as being worthy of a recognition for possibly having a beneficial effect on suicide risk? And the FDA, and we said there are at least a half a dozen of the trials that are prospective, randomized, and placebo-controlled where lithium was significant. And they went for some months, finally got the reviews back from the FDA, and they said essentially, nice try, but we're not going to buy it. And the reason was that most of these studies had to do with suicidal behavior as an incidental finding. That is, the studies were not designed to test for suicide as the outcome. And to that, I can only say good luck, because who is going to have the courage to design a study, let's say against placebo, where the outcome is fatality? I mean, it's just not going to happen. Anyway, we have pursued this question, and very recently, Tondo and I have an editorial in the JAMA Psychiatry journal, and we put together these data from a modest number of randomized controlled trials. The most recent one is the bottom study by Katz, a big VA study that was published last month in JAMA Psychiatry, and that was a study deliberately designed with suicidal outcomes as the defined outcome. All these other studies, the suicidal outcomes are incidental. That is, they were by luck comments about adverse effect outcomes. Whatever they are, they were randomized, they were double-blind, they were placebo-controlled, and there's a huge impact of lithium against placebo. These are fatalities, these are actual, and attempts, but severe suicidal behaviors, and the overall difference is substantial and highly significant statistically. So I think I'm about out of time, and I think I'm going to quit at that point, and again make the point that if there is something to this notion that there may be a biomedical therapeutics that might be pertinent for suicide, I think at this point it's still quite preliminary, and other than data with Clozapine in psychotic illness and lithium in bipolar disorder, possibly in some cases of unipolar depression, and with some recent experimental treatments that are being used in depression that may have effects on suicidal, at least thought, not so much behavior at this point. I think there's something brewing there, and I think it's an area that deserves further study. And I think a decade ago, most people would have dismissed this as being hopelessly optimistic. I think it's something worth looking at. Again, the main points that I've made, to repeat them, the point: major mental illnesses can be fatal, suicide usually in younger people, and responses to general medical illnesses in older patients, and the numbers of dead persons at the end of the year are similar from both kinds of causes. Suicide risks have been declining in many countries, have been rising for the past decade or two in the US, although very recent data from 2019 suggests that the risk may be leveling off or even slightly declining. Suicide risk by diagnosis is very high in bipolar disorder, both type 1 and type 2. Also high in substance abuse, especially polyabuse. We have proposed this ratio of attempts to suicide as a measure of lethality of suicidal behaviors. It averages about 30 or 40 in the general population, below 10, and as low as 5 in bipolar disorder. That is 5 attempts for every suicide. Therapeutic interventions, again, can increase the AS ratio, that is, decrease apparent lethality. We've shown that with lithium in the past. Risk factors, we know a little bit about these kinds of risk factors: prior attempt, substance abuse, major mood disorder, and so on and so on. The problem is that all these risk factors hold up nicely for population samples, and they are strong statistically, but from a clinical perspective, they have limited utility. We use them, I mean, they're part of everyday sound clinical practice, but the ability to predict who's going to do it and when they're going to do it or how they're going to do it, that's tough. And that's really a clinical challenge and requires us to rely on all the things that we've learned over the past century that make psychiatry such a challenging profession. Medical treatments we've talked about, I think, enough, and I'm going to quit at that point. And if there's a question or two, let's see if we can deal with those. Thank you for listening.
Thank you so much, Dr. Baldessarini. Always very much to the forefront of data, and there is always this excitement of your during your lectures of producing new data, and we're all very, very thankful for this. We have some questions, and I'm going to take them as they have come in. From Dr. Hassanig, personally, I am very reluctant to prescribe antidepressants to young, especially male, depressed quote-unquote patients, something that I call apparent first episode or major depression. Often they are without clear history of hypomanic, manic mixed episodes, deny familial history of bipolar disorder. However, I am cautious. Am I wrong?
I think you're very right, and I certainly would say amen to everything that you've said. I think one of the great challenges, and one of the things that we're spending a lot of time in our current research, is to try to improve early diagnosis and recognition of bipolar disorder as distinct from unipolar major depressive disorder. This is a very, very difficult challenge in children and adolescents. Dr. Tsipakis and I know this very well from having reviewed that literature some time ago together. I think that the big fear that many people have, there's several bases for the uneasiness. One is that I think the status of conceptualization and diagnostic criteria for major mood disorders in children remains a little early and a little imperfect and a little insecure, I would say. That's a rather generous comment. It's actually tough. And to be able to recognize bipolar disorder in kids is really difficult. And a lot of the phenomena that go with early onset mood disorders overlap with those that go with bipolar disorder. That is, if you have early onset in adolescence, for example, or even earlier, and you have multiple episodes, these are things that happen commonly in kids, but there are also criteria that make you think about bipolar disorder. How do you sort the two out? This is one of the great challenges of all the clinical skills that we have. You have to dig in deeply into the past history. You have to talk not only with the patient, but with people who know the patient really well. The idea of getting somebody to recognize, for example, hypomanic episodes, very difficult. Many patients are shocked when you raise the possibility that they've ever been hypomanic. And their response is, what do you mean? Why are you psychopathologizing my good moods? That's me at my best. That's not a sickness. And there's a terrible prejudice about recognizing hypomania in particular. But I think early onset, multiple episodes, certainly mixed features, psychotic features, family history is important. All these things help you with early diagnosis. But even then, I agree with your position that if you're going to treat with an antidepressant in a young person, be very, very careful. And I think that the good news about it is that while switching into hypomania or mania or psychosis occurs in young people starting with an antidepressant, it's not like a thunderbolt coming out of a blue sky. These are things that you can see coming. So if you know the patient well, if you follow them closely, whether in person or by telephone or however you're doing it, especially in the beginning of the treatment trial, you can see it coming. You will see sleeplessness, agitation, irritability. I'm sorry. That you can see the thing coming, you can do something about it. And the first thing to do about it is to back off on the antidepressant and maybe add in something that's a little more soothing, sedative, an antipsychotic, lithium, whatever seems to be appropriate. But I agree with you, this is a very risky, challenging clinical problem.
Thank you, Dr. Baldessarini. Moving on to a couple more questions. Dr. Chetri, is the high risk for suicide post-discharge for all psychiatric cases? What could be the possible reasons for the high risk?
This is asking about post-hospital suicidal
Discharge, yeah.
I think this is very, very painful for me to talk about because it really gets into airing dirty linen in public, and it may be largely a US problem, I don't know. I mean, our systems for caring for psychiatric patients are really leave a lot to be desired. The funding and support for psychiatric services is poor. I think the ability to get people into hospital, take care of them, and then to provide for aftercare are all less than what one would like to see. And I think it's not so much in the descriptors of the clinical problem that you need to worry about, or about people signing out against advice and putting themselves at risk because they really want to die. That happens sometimes. I think it's uncommon. What I think is going on is that we're sending people out the back door who are still sick. And we've done some studies over the past year showing that as lengths of stay were cranked down by administrative fiat back in the 1990s, we saw our length of stay in our hospital drop from an average of 6, 7, 8 weeks down to 1 or 2 weeks. And the rate of rehospitalization or major breakdown after discharge, they went through the ceiling. And I think that the problem is that, and we documented that people were being sent out still quite symptomatic, certainly much more than they had been in the earlier days when lengths of stay were longer. There's so much pressure, at least in the States, to get people out of the hospital that I think we're sending a lot of people who are barely beginning to get better, barely recovering, and are still very unstable, quite symptomatic. And I think they're at high risk. I think that it's as simple as that. So this is why I say I think doing a better job at organizing a structured, dependable, maybe actually try it out before the patient leaves type of aftercare is really important. I think it can save lives.
Thank you. And one last question. Is there any role of clozapine in chronically suicidal patients, especially for those with personality disorders?
You're asking about clozapine?
Clozapine in chronically suicidal patients, and especially for those with personality disorders.
I think the academic answer to that is only if the diagnosis is schizophrenia. I mean, I wish it were true across the board, but these are studies that have yet to be done. And I really encourage more work to be done, especially about suicide in people with mood disorders, particularly bipolar patients, where I think clozapine probably has some utility. Again, this is tough work. Doing anything to test for anti-suicide effects is extremely dangerous, risky, raises liability concerns and legal risks and so on. It's very, very hard to do. And with clozapine as the test agent, it's doubly difficult because clozapine, as wonderful as it can be, is a potentially very difficult drug. lots of bad side effects. Ileus, cardiac arrhythmias, there's the whole leukocyte suppression and sepsis. And there are many, many life-threatening risks that make it doubly hard to do. But, you know, it's being used for schizophrenia, so I think it might be nice to have some data in other disorders. Enough for one day. Thank you for listening.
Thank you. Thank you so much for being with us. Thank you.
We could make a short comment, myself and Peter. Peter, are you with us? Okay, I will start, and then Peter might join. First of all, Professor Battisarini, thank you so much for your interesting speech. I myself love maps, and the map of the US. I have just published a paper on the suicidality in the US in the first half of the 20th century until the Second World War. And we have also worked on maps of the US and maps of Europe. And in the US, it's impressive that the Rocky Mountains split the country into two, and how a lot of factors, including population density, race, economic condition, the Appalachian states are very poor and problematic, and also the terrain determines what race occupies the terrain. For example, the southern states have a lot of Hispanics, the Great Plains have only Anglo-Saxons, white people, and the big cities have African Americans, and the European descendants in the US have similar suicidal rates than in continental Europe. So it's very interesting how all these factors interplay in the US, and also climate. If you see the climate map of the US, it has a lot of similarities with the suicidal map, and the same holds for Europe. For Europe, the gradient of suicidality is from south to northeast. It's not south to, it's south to northeast.
Right.
I don't want to take much time. I just have a final comment on the question, on the last question, what we do with personality disorder patients, with borderline personality, which are chronically suicidal. Now, the big question here is this a personality disorder? Because this answers the question why the New England and other journals have this kind of behavior and attitude towards psychiatry, because we are very much inclined towards psychosocial interpretations of even of lethal, of very, very serious conditions. So if this, my answer would be that lithium might be useful in this case, because it's probably some kind of sub-threshold mood disorder, if not a real mood disorder.
Could I comment? That I see lithium being used empirically more and more broadly these days, but I don't see papers. You know, people are not doing studies aside from bipolar patients to look for lithium effects in borderline disorder and other conditions. And I think it's another area that there's an opportunity to do some work. Maybe some good.
You know, one problem with trials in the meta-analysis you showed, the biggest problem is that individual trials were negative. Yes, the meta-analysis was positive, but individual trials were negative, and this is one of the major reasons why the FDA didn't want to approve an extra labeling for lithium. And who's going to pay for these studies? Nobody will pay. There are no grants for this kind.
Well, that's been the problem with lithium from the beginning. It's always been a poor orphan drug. No patent, no commercial interest.
Yeah. Peter.
Well, yes. Well, for me, it was extremely interesting paper, and I remember I know Dr. Baldessarini for about 50 years, I think, 40 at least. We met in Florence, I think, during the Congress. And at that time, I remember we talked about one WHO study in which I participated. I remember that time it was multicentric study, and Hungarian participants show us the highest level of suicidality rate in their country comparatively to some others. And what is interesting, they do themselves quite interesting comparative study within Europe and show that the suicidal rate is linked not with climate, but the latitude of the place. And it was Zoltan remember it probably. I think it'll be a good bridge to pass the floor to him, because Hungary is always in this serious interest to the problem of suicidality, coming back to Austro-Hungarian Empire, in which, generally speaking, within this border, the rates of suicidality was very high in Europe. But for me, it was interesting, this factor of latitude, which is, I don't know, it was confirmed later or not. But frankly speaking, in general, I was very impressed by the comparative assessment of different countries, because for me, it's also an enigma why, for instance, in Russia, such decrease in the last 10 years. I asked sometimes Norman Sartorius about, and he told me that it is general tendency and nobody knows even why. Because, for instance, in one region in Russia, so-called Astrakhan, it's down in the bank of the Volga River, the level of suicidality is simply zero, which is, it's very difficult. And my question was, if there are any relationship between the level of lithium in the water of the Caspian Sea and the Volga River to this level. I don't know. There are many speculation, many different hypotheses, but this overview was very spectacular, very interesting, and stimulate our brain activity for a long period. Thank you, Dr. Baldessarini. I always follow your papers.
Thank you. Could I ask one question? Do you know how solid the data are about latitude in the Southern Hemisphere? Does it work in the Southern Hemisphere as clearly?
I'm so sorry.
The same. The relationship of suicide rate and latitude in Southern Hemisphere is the same. The more close is in the country to the equator, the lower is the suicide rate.
Yeah, that's my impression. I just didn't know
Exactly.
how good the data were. Yeah, good.
The problem with the Southern Hemisphere is that most of land area is in the North Hemisphere.
Yeah.
And the North Hemisphere has a different shape of land mass, which permits a different ecosystem. Africa is vertical, while Eurasia is horizontal, and also the Americas is. So this makes comparisons impossible. But the climate is important. It's not temperature. It's probably
Sunshine?
No. How rapid, how fast temperature changes.
I see.
From spring to summer, and from summer to winter. And for example, in Greece, it has four changing points. In other countries, it has only 2. This is why it's so difficult to clarify things. In the US, there are 5 different climate zones, climate areas. And the most interesting thing in my eyes was that California, which is the only the only area outside the Mediterranean who has a Mediterranean type climate has so low, as low suicidal rate as it is in the Mediterranean area. It's interesting, but also there are many Hispanic people there, so this could be a bias.
One of the great ironies in this geography is, do you know where some of the highest suicide rates are? I'm sorry,
In Alaska.
lowest.
The lowest in New Jersey.
DC.
DC.
Washington, DC, very low. And I would have thought Washington would be one of the highest because it's such a stressful place.
And New York City state.
Yeah.
Something like 6. It's similar to Greece and Italy. It's impressive, the difference. So, Daria?
Off to the Ria Smirnova now, Professor Smirnova.
Thank you, Ross, again.
Thank you very much for the invitation.
Thank you very much for lecture, for amazing discussion, very interesting discussion. And now I move to the introduction of our second speaker, Professor Zoltan Rimer. Dr. Rimer is a professor of psychiatry at the Department of Psychiatry and Psychotherapy and scientific director at the Department of Clinical and Theoretical Mental Health in the Semmelweis University in Hungary, and also a director of the Laboratory for Suicide Research and Prevention in the National Institute of Psychiatry and Addictions in Budapest, Hungary. Professor Rimer has 3 special qualifications in psychiatry, in neurology, and clinical pharmacology, and he received his PhD by Hungarian Academy of Sciences in 1993 and his Doctor of Sciences degree in 2004. His special interest is clinical and biological aspects of mood and anxiety disorders, with particular regards to prediction of treatment response and prevention of suicide. And an additional interest of Professor Zoltan Rimer is the interface of mood and cardiovascular disorders. Professor Rimer has published more than 450 papers, and his cumulative impact factor is above 500, and the number of independent citations exceeded several thousands. And what is important also that Professor Rimer received numerous awards, and the award of the Department of Child and Adolescent Psychiatry by Columbia University, New York, and also award of the Hemingway Foundation, and also the award, Lifetime Achievement Award of the, of course, Hungarian Psychiatric Association he serves, and the Aristotle Gold Medal of Lifetime Achievement in Mental Health given by the International Society of Neurobiology and Psychopharmacology. Professor Rimer is a member of several association and executive committee and the boards of national and international associations, including European Psychiatric Association and European College of Neuropsychopharmacology, and also editorial board member of influential peer-reviewed journals such as Journal of Affective Disorders and International Journal of Psychiatry and Clinical Practice and World Journal of Biological Psychiatry. There is an interesting paper published about Professor Zoltan Rimer in Psychiatric Bulletin by Cambridge University Press. And there was a question which Dominic Fennan asked Professor Rimer, how would you like to be remembered? And Professor Rimer said, I would like to be remembered as a man who did something good for his family, his patients and colleagues, and who will live till the age of 100 with good mental health. And I think this is really a great example of the desire for life and really anti-suicidal behavior, which is, you know, very important for today's topic. And Professor Rimer also visited Russia many times, and we listened to his lectures also at Suicidal Early Career Psychiatry School. So now Professor Rimmer joined us to share his knowledge with Greek and international psychiatrists at this Master of Sciences in Clinical Mental Health webinar. So thank you very much, and we are happy to collaborate with your good colleague, Professor Ksenia Gonda, and Semmelweis University within different studies. So Professor Zoltan Rimmer will talk about social and environmental variables in suicidality as a phenomena. So the floor is yours, Professor Zoltan Rimmer. Thank you.
Good afternoon or good evening, dear colleagues, ladies and gentlemen. First of all, I would like to thank the very nice, kind introduction of you. I have been really several times in Russia, in Suzdal, and I have learned also Russian in the primary and secondary school. But my lecture is today on the social and environmental factors in suicidality. Many, many thanks for the kind invitation of Professor Javed and Professor Funtoulakis. He gave me a very good topic because I have been mainly recognized as a biological psychiatrist in quotation marks, but I am clinical psychiatrist. I am full-time clinical psychiatrist whose main interest, mood and anxiety disorder, suicide, and relationship between mood, anxiety disorder, and cardiovascular disorder, and so on and so on. Very heavy topic, very, very big topic, social and environmental factors in suicide. Practically nothing to declare regarding to this lecture, and very, very big topic, and it was very difficult for me to choose the most appropriate slides. We know that suicide is a very complex, multi-causal human phenomenon involving several psychiatric, medical, psychosocial, cultural, and demographic risk factors, both on individual and both on ecological level. And in spite of the fact that about 90% of suicide victims have at least one major mental disorder at the time of suicide, mostly untreated, and most frequently major depressive episode, mainly bipolar, bipolar 1 or bipolar 2, unipolar major depression, substance use disorder, and schizophrenia. It means 90% of the victims have current, mostly untreated disorder, psychiatric disorder at the time of suicide. But from the other hand, the majority of suicide victims are untreated, and major mental disorders is necessary but not sufficient condition for suicidal behavior, because the majority of psychiatric patients never commit, and also the majority of psychiatric patients never attempt suicide. And this way, beside the major mental disorders, other factors plays also a very important role, like special clinical characteristics, depression, bipolarity, agitation, mixed depression, insomnia, hopelessness, comorbidity, mostly substance use comorbidity and anxiety disorder comorbidity, genetic familiar factors, including family history of psychiatric disorder, family history of suicide, and early adverse life events and some familiar negative life events and stressors. Personality or temperamental factors, very important, impulsivity, aggressivity, affective temperaments, because there are a lot of studies indicating that hyperthymic temperament is protective, but depressive, cyclothymic, particularly cyclothymic or irritable temperaments are risk factors for suicide if persons showing this temperament profile became depressed or mixed. Demographic factors, very well known that males and old people are more vulnerable for suicide. Psychosocial factors and environmental factors, two main focus of my lecture, and of course, cultural factors plays very important role. Which are the most important psychosocial, psychological factors, social factors which related to suicidal behavior: unemployment, low income, access to health care, insurance, separation, divorce, isolation, life events, religiosity, spirituality, and it's very important to note that they are interrelated. Unemployment, low income, the studies have clearly shown a significant relationship between unemployment or low income or bad financial situation between and suicidal behavior in individual level and also on the level of general population. This is a very frequently quoted paper from the Lancet. The showing that this meta-analysis shows that 1% rise in unemployment, it results in about 0.8% rise in suicide rates. This is also true for individual level. We published several years ago a case-controlled suicide study, almost 200 suicide cases and the same number of controls. And we have found that the rate of unemployment among suicide cases in 2001, when we performed this study, was 17%, and the same rate in control population was 3%, and the same rate in the general population of Hungary that year was almost 6%. It's also important. Another studies, a big meta-analysis shows in 54 countries that after the 2008 economic crisis, the rate of suicide mortality increased in European and in American countries, particularly in males, among males, and among areas, among countries, among regions with higher level of job loss. Another important study from UK, Professor Keith Houghton published this paper, and he have found that increased rate of self-harm were found in areas where there were the greater increase in the rates of unemployment. The strong relationship between unemployment and suicide mortality is also present in Hungary. We have published this small study in Lancet several years ago, but we have found that the sharply declining suicide mortality of Hungary started to decline when unemployment rate increased. It should be noted that the suicide rate of Hungary was among the highest on the world, as we have discussed earlier. 35 years ago, the suicide rate of Hungary was 46. 46. 35 years ago. That time, the suicide rate of Greece was almost 4. More than 10 times difference. But in the last 35 years, the suicide rate of Hungary declined year by year, steady, consequent decline year by year, and in 2019, it was 16, 46 to 16. it is 65% decline. There are a lot of explanation or a lot of factors that can explain this big decline, but it is not the topic of this lecture, but I should mention that we have made a lot of studies and deep analysis, and we have found that the better treatment of mood disorders is the main factor in this very, very favorable change, because 65% decline in suicide mortality, and the prescription of antidepressants, which is just a proxy marker, I know, prescription of antidepressants increased 14-fold during these 36 years. But we can discuss it later in a frame of another lecture. With the cooperation of Professor Fountoulakis, we have also found that the relationship between unemployment and suicide is not so direct that somebody became unemployed today and will suicide tomorrow. We have found that permanent unemployment is needed, in quotation marks, and about 3 to 5 years delay is between became unemployed and depression, and you know, depression and suicide are very strongly related. It means that the transmitter between unemployment and suicide is major mental disorder, particularly depression. There are several review papers indicating that the relationship between unemployment and suicide is bidirectional. Unemployment can result in provoke or can be a risk factor for depression and suicide, but the another side, it is also true that depression can frequently result in unemployment, and unemployment and depression together is a very high risk for suicidal behavior. And another study have shown that unemployment is an extremely powerful indicator of the rates of serious mental illness. The Italian study also have shown that unemployment rates increased with increasing mental illness severity. Mental illness, it alone is not enough, because the majority or a big part of mental illness are not so severe, fortunately, and more mental disorder patients could be treated as outpatient, on the outpatient basis. But the more severe is the illness, mostly depression, schizophrenia, or mania, of course. Bipolar patients creates the most life events, because you know the life events can be independent, something tragedy, independently of mind behavior, but can be dependent. And bipolar patients, particularly bipolar 1 patients, during the manic phase create a lot of conflicts, and which later can be a risk factor for suicide behavior if bipolar 1 patients switch from mania into depression. Also, Professor Fountoulakis and a lot of his European colleagues have investigated this relationship, and which is the most important, at least from my side, that economic environment. Unemployment, it's okay, but economic environment, it is a more precise, because unemployment, the category of unemployment is very heterogeneous. As I have mentioned, to be unemployed for 3 months is not the same to be unemployed for several years. And what is the situation in Greece? If I have mentioned Professor Fountoulakis, the suicide rate of Greece in 2000 was 3.5, and 15 years later, it became almost 5, which is 33% increase. And the unemployment rate correlated with suicide rate only in males younger than 65 years old. Of course, it is very important. Income per capita income is very strongly related, of course, to unemployment. It is not surprise that it is a relationship. Access to healthcare and health insurance. It is also very well demonstrated a significant relationship both on individual and population level. This is a very so-called old study conducted about 30 years ago when we analyzed the suicide rate, prevalence of diagnosed depression, and prevalence of working physicians in Hungary. And we have found, we analyzed 20 regions of Hungary. The size of Hungary is 10 million people. 10 million people, and we have 19 counties and one Budapest, and this way we had 20 regions, and the size of population in every region average is 500,000. And this way the statistical analysis is possible, and we have found that the higher is the rate of working doctors in the given region, the higher is the rate of reported, higher is the rate of diagnosed depression, and lower is the suicide rate. It should be noted that in another study we have also found that no such relationship is with schizophrenia. But it is not a surprise, because our psychological autopsy studies showed that the rate of schizophrenia among suicide victims in Hungary was 8%. And this 8% is not big enough to make a statistical association. But the rate of mood disorder or depression, major depression among suicide victims, 60 to 70%. And this way, this was probably the first study on the world, nobody quotes, when we demonstrated that access to healthcare is very important for diagnosing depression and for preventing suicide. It should be noted that years, 1993, it was published in 1993, but the study is on the data on 1986, where the suicide rate of Hungary was on the top. The depression was very much underdiagnosed. But fortunately, the situation became better and better. And as I mentioned earlier, 14 times increase the antidepressants prescription also indicates that the diagnosed depression in Hungary increased also. This study has been supported by American study by Professor Tondo. Professor Baldassarrini have mentioned this study. It has been supported in Austria, in Finland, and in Slovenia, showing that availability of mental health services and quality of depressive disorder treatment significant relation with suicide. Divorce, separation, isolation, also very well known that there is a significant relationship on individual and population level. The study I have mentioned earlier, among suicide cases, the rate of separation and divorce was 33%. The same in contrast was exactly the half, 17.5%. But looking at these relationships on the level of general population of Hungary, with Professor David Lester, we have found that the higher is the rate of divorce in a given region more than 30 years ago, the higher is the rate of suicide. Looking at the whole population of Hungary, in 1 year, the number of suicide victims in Hungary in last years was 1,700, but that year the number of suicide victims was much higher. And we have also found that marriage was a significant protective risk factor against suicide, at least in statistical relationship. But looking at the decline of suicide mortality in different subgroups of suicide victims in 2016 years later, we have seen that the greatest decline in suicide mortality, almost 60% decline, was among married persons. Widowed persons decreased the second greatest, among 56%. Separated or single persons' suicide is decreased by 28 or 26%. And it also indicates from a very, very different point of view that we have found the same marriage is a protective factor for suicide, but it does not mean that widowhood is also protective, but it also needs a very, very detailed discussion. Yes, another study also from Italy also shows that the protective impact of marriage or living together is higher for suicide than for natural causes of death. Separation and divorce, it is practically the same. Nowadays in Hungary, the rate of divorce decreased because the rate of marriage also decreases, of course. Life events. It is very well known that life events can risk factor for suicidal behavior, either early negative life events. It is very well demonstrated that in suicide victims and in suicide attempts, the rate of early negative life events is significantly higher than in the controls or non-suicidal mood disorder psychiatric patients. And life events in adulthood can be a trigger of suicide, but suicide is really a very complex, and suicide is never the consequence of life events alone. Looking at, again, our case-controlled studies, and we have also found that among the 194 suicide cases, the adverse life events in the last 3 months were more than 40%, and the same in control population was just 17%, more than double difference. Religiosity, significant relationship, both on individual and population level. Again, the same study. Don't believe that we have just one study. We have published several studies, but this study is very good for demonstrating the psychosocial risk factors for suicide in Hungary. And the practicing religion is almost 16% in cases, and among controls is almost 35%. It is also a double difference. Yes, religion is protective factor against suicide, regardless of the nature of religion. Looking at the whole population of Hungary and using the database of Central Statistical Office of Hungary, we have also found that lack of religious integration was related significantly higher suicide risk. Professor Pompili from Rome, who is among the leading experts of suicide, I am sure everybody know him, have made a comment to a paper, British Journal of Psychiatry, and he pointed out that stigmatization of mental illness can prevent people from seeking treatment, and many stigmatized psychiatric patients believe that the suicide is the best resolution. And it is, of course, not the case. What are the environmental factors related to suicide? Geographic, climatic factors, socio-cultural factors, alimentary factors, COVID-19 pandemic, and lethal methods. Geographic factors, we have discussed it earlier: latitude, longitude, and altitude, elevation, sunlight, temperature, air pollution, green spaces, seasonality, periodicity, lithium in drinking water, and arsenic in drinking water, latitude. The higher is the latitude, the higher is the suicide rate. Significant relationship on both hemispheres. More close is the given country or region to the equator, the lower is the suicide, and it is also true from southern hemisphere. But it's very important to note, as I have mentioned earlier, that hyperthymic temperament is protective against suicide. And in this very interesting Japanese study, when the authors investigated the temperament, the prevalence of different affective temperaments on different latitude, in Japanese Sapporo, Goshiega, and Oita, 43, 60, 36, and 33 grade, and they have found the lower latitude more close to the equator, more sunshine, more hyperthymic temperament, as there are a lot of papers investigating this relationship. And as I mentioned, hyperthymic temperament is the only temperament out of the 5 Kraepelin-Otyskal temperament which are protective against suicide. And this relationship has been found in every country, when in Hungary, in Italy, in the United States, and so on and so on. Longitude, suicide rates are also significantly related to longitude. Western United States are higher, and in Eastern Europe, Professor Funtulakis and Professor Baldessarini also have mentioned, and it means in Europe, not just southeast, south, north, and this way, if we look at the map of Hungary, the higher is the suicide rate in northeast. Altitude is very important, as I have mentioned. Longitude, latitude, longitude, and altitude, because there are at least 2 American studies looking at more than 2,000 counties in the United States, and significant positive association with the altitude or elevation and suicide mortality, even after controlling for age, percent of male, percent of wife, household income, population density, and weapon, having weapon, guns. Then it's very interesting. It's very interesting, and in my view, it can explain some East and Western difference in suicide rate in the United States. Significant association of persons, another study. And the explanation was hypoxia, temperature, lot of fish consumption. It is my explanation. Low lithium in drinking water. It is also my explanation, because we have discussed earlier that lithium in drinking water is also strongly relates to suicide behavior. The lower is the lithium in drinking water, the higher is the suicide rate. Almost every study have found this. It is also a different question. It is it is very important topic. How can be it? Because lithium in drinking water is at least 500 or 800 times lower than in the therapeutic dose. But the relationship between lithium in drinking water and suicide, it is quite strong. And I have mentioned to some Austrian colleagues, Professor Kapusta, that it would be interesting to look at the lithium in drinking water in high mountains. And it is another study which is not the central topic of my lecture, but it has been found. The higher is the elevation, the higher is the altitude, the lower is the lithium in drinking water. But summarizing this, the geographic latitude, altitude, and elevation makes the relationship between suicide and some geographic factor three-dimensional. And it can explain. I am not sure that it is the full explanation, because Professor Funtoulakis and Professor Baldessari have mentioned several other factors. I am not sure it is the full explanation, but I think it is one important part of this. Air pollution, statistical association between air pollution and suicide risk, significant association, very small effect size, and also a statistical association between green spaces and suicide rates. The higher are the green spaces, the lower is the suicide rate, but they are related because there are more green spaces, lower suicide rate, but more green spaces means less air pollution. Seasonality. Seasonality of suicide is also a very well-known phenomenon. Spring and early summer peak and winter low, it is a typical pattern, which is also true for the southern hemisphere. It relates the name of the season, not to the name of the month. Spring, early summer peak, winter low. But dividing the suicide victims into at least two parts, mood disorder related suicide and other, we can see that suicide related to mood disorders have significantly more pronounced seasonality of suicide than non-mood disorder suicide victims. And this way, we can detect the effect of better treatment of mood disorder in declining suicide rate, because we have found, we published another paper, which is also not the topic of this lecture, that the bigger is the increase of antidepressants prescription or antidepressants use in the given regions, the smaller is the seasonality, the smaller is the amplitude of seasonality of suicide. Very, very interesting topic, distribution of suicide during the days of the week. And it is very universal finding, Monday peak and weekend low. The low in males is on Saturday and low in females is on Sunday. But everywhere on the world, when they investigated the authors, Monday peak, weekend low. And in contrast to seasonality of suicide, which is mostly related to biological factors, the weekly distribution or weekly fluctuation of suicidal behavior is only social factors. It is another topic that you know, Regio Sheres, Gloomy Sunday, very famous song, Gloomy Sunday, and the composer of this very famous song also committed suicide. Another very important paper, Professor Funtoulakis meta-analysis, and they show that most reports suggest that suicide rates are higher during periods of high temperature, low rainfalls, and more sunshine, and the change of climate is more important than the permanent factors. Lithium in drinking water, we have touched several times. There are a lot of papers. Probably the most recent paper on this topic is in the middle of this slide. We have also found that in Hungary, the higher is the lithium in drinking water, the lower is the suicide rate, particularly among males. And it is very important. This also supports the causal relationship, because we know that lithium, in addition to its mood stabilizer effect, lithium has a very strong anti-aggressive and anti-impulsive effect. And we know that the suicide of males is more aggressive, more drastic, and more impulsive. This is very important. And Professor Leo Scher from United States also have found and published that lithium has an anti-androgen effect, and then the androgens, testosterone, plays also very important role in suicidal behavior. Yes, and then we can consider that lithium in drinking water and suicide are really strongly related. It is not absolutely resolved problem, but I can believe this causal relationship in spite of the fact that, as I have mentioned, lithium in drinking water is much more lower than the therapeutic dose, because another study, which I also very frequently show in my another lectures, another American study, endocrinologists have investigated thyroid function and lithium in drinking water and another several biological parameters. And they did not know anything about the lithium and suicide in drinking water. And the study have found that the higher is the lithium in drinking water in the United States, the lower is the thyroid function. Very small difference, but significant. And this is the argument, at least for me, that the causal relationship, because we know that hypothyroidism, declining thyroid function, is the most important side effects of lithium therapy. But we should leave lithium. Meta-analysis, at least 13 or 14 studies, mainly among males. Arsenic. We have also investigated the arsenic in drinking water in Hungary, because several regions in Hungary, the level of arsenic was very high. You see, the norm is less than 10 units. Less than 10, it is a norm. And we have found that the higher is the arsenic in drinking water in Hungary, the higher is the suicide rate, significant relationship, small effect size, and very interestingly, the high arsenic level in drinking water and the low level of lithium in drinking water is particularly characteristics of southeast part of Hungary, where the suicide rate is the highest for the last 150 years. You can see there is a line in Hungary. Suicide rate is more than double in southeast Hungary than in western and north part of Hungary. Another environmental, alimentation, alcohol, COVID, pandemic, and suicide methods, traumatic events. Tryptophan, very interesting study. Professor Voracek from Austria have found that the higher is the tryptophan intake in 42 countries, the lower is the suicide rate. Strong relationship. And tryptophan is the precursor of serotonin, you know. And serotonin plays a very important role in suicidal behavior. Safe food, safe mood. The American colleagues from the Professor John Mann research group have found a significant negative correlation between I'm sorry. This is the first study, the fish consumption. Significant negative correlation because between seafood consumption and lifetime prevalence of bipolar 1, bipolar 2, and bipolar spectrum disorders, but not with schizophrenia in 12 countries. It's very, very important. I am sure. I am sure you know very well. And this is the study I have mentioned earlier. Professor John Mann and colleagues have found that during the 2-year follow-up, high omega-6 per omega-3 ratio or low omega-3 was a significant predictor of suicide behavior. And you know, omega-3 fatty acid is a very important protective factor, not just for several psychiatric disorders, maybe postpartum mood disorders, but also for cardiovascular disorders. Vitamin D status is also an environmental factor, of course, and a big meta-analysis shows a link between vitamin C deficiency and impulsivity and aggressivity, and it means that vitamin D deficiency may increase the inflammatory cytokines in the brain, which can reduce the serotonin activity. Also serotonin, alcohol, very well known. Maybe you remember, if you are not very young, the Soviet Union perestroika before the collapse of communism. It was a big development, big changes. President Gorbachev wanted to, he was really a great man, in my opinion. And during the perestroika, when alcohol prohibition, the decline of Soviet men, the suicide rate of Soviet men declined by 40%. After the alcohol prohibition, suicide rate of Russian males increased again, while the same decline in European community, look at the second and fourth column, was very small. And it means, according to Professor Danuta Wasserman, it is the most successful suicide prevention program for males. 40% decline immediately after the alcohol prohibition. Males, and in Russian females, this decline was also remarkable, 20%. The same is in Slovenia, in several other countries. What about the COVID-19 pandemic? It's no doubt that during the COVID-19 pandemic, the incidence or prevalence of depression, particularly severe depression, increased dramatically. It is a very well-known American study indicating that the rate of severe depression during COVID pandemic increased 7-fold. You see, the moderately severe depression increased 4-fold, moderate depression increased 2.5-fold, and so on and so on. It's no doubt depression and anxiety disorder increase. And there are several ways when COVID pandemic can result in higher rate of depression and suicide, depression, anxiety, isolation, illness, where COVID infection itself, unemployment, reduced physical activity, loss events like grief, reduced medical and psychological care, and all these factors can result in or can contribute to suicide. But in the first half of the pandemic, looking at this Lancet paper investigating the 16 high-income and 5 middle-upper-income countries, no significant changes in suicidal behavior has been detected between 1st of January of 2019 and 31 July 2002. But a little bit later, in Japan, it have found that the suicide rate increased dramatically. And in Hungary, when I have mentioned that from 1986, when the top suicide rate was big decline till 2019. You see, 2019, the suicide rate of Hungary was about 16. And in 2020, the suicide rate increased dramatically by 16%, particularly among males by 18%. And it is a very recent study and very recent findings. But according to the Hungarian experts, COVID pandemic could be the only or the major factor that can explain this increasing suicide mortality. But of course, very well known that the domestic or car exhaust gas, carbon monoxide, guns, pesticide, physical availability barriers are very important factors in creating suicidal behavior. And finishing the lecture, we know that suicide is a complex phenomenon. High-risk persons in a high-risk period became suicidal. High-risk patients, a family history of suicide, prior suicide attempt, impulsivity, and so on and so on and so on, life events. High-risk period, acute stressors, spring, early summer, and so on and so on. And protective factors can not compensate, but can mitigate or minimize the effect of these suicide risk factors. Family support, treatment, it is very important, as we have learned from the study of Professor Baldessarini. And most interestingly, the majority of psychosocial, the majority of protective factors against suicide are psychosocials in origin. Good family, social, financial, medical support, high number of children, pregnancy and postpartum period, practice religion, elimination of lethal methods if it is possible, hypersomnia in major depression, and hyperthymic temperament are the two factors which are not social and environmental, but regular physical activity and treated mental disorders are also very important in preventing suicide. And the conclusion, suicide is in a given country or region is the result of complex interplay of several factors. And beside the individual suicide risk factors, like depression and so on, there are several psychosocial and environmental correlates of suicidality, which show the significant association but small effect size. And considering all the above, it is very important in suicide prevention. Thank you very much for your attention.
Thank you very much, dear Professor Zoltan Rimer, for your amazing lecture, thought-provoking lecture. And we have several questions. One question goes from Professor Afzal Javed, WAPA President. Should we consider etiology of suicide as a psychosociological issue or of biological origin?
Yes, my answer on this question is that in spite of the fact that psychological, demographic, cultural, social aspects are very important in suicidal behavior, persons with suicide attempts or persons who will commit suicide are transferred always to psychiatry and not to office of unemployment, not to psychology, not to church, and not to Institute of Sociology. And this way, the last word, the first and last word in suicide prevention is in our mouth. We take the responsibility. Psychologists, sociologists, demographists, statisticians, teachers, gatekeepers, priests, policemen, fire extinguishers can help us, because policemen are very important in suicide prevention in a given time, in a given place. But at the end point of suicidal person is not the Institute of Sociology, Institute of Culture, not the church. I consider religious is a very important factor. Of course, I won't make a lot of joke, but psychiatry. We took the responsibility. And when the patients, the suicidal patients, has been discharged from the hospital, we should organize the aftercare. It was also a topic. Fortunately, Hungary is a small country, 10 million people, relatively small, and the aftercare of psychiatric patients is very well organized. More than 60 years ago, every inpatient department of psychiatry, the number of them is about 50, all inpatients number of psychiatry were strongly connected to one outpatient department of psychiatry. And when we discharged the patient from our inpatient department, we made discharge paper in 5 copies, one for patients, one for the chart, one for the GP, one for the outpatient psychiatric department, and another one. This way, every discharge paper, so obligatory to report to the outpatient department, and mostly mood disorder patients are treated or the outpatient department or for inpatient unit, of course, but the majority of discharged psychiatric patients to send immediately to outpatient care. Yeah, and this way I think suicide is a medical problem with several psychosocial, socio-religious, cultural, and so on aspects. But we took the responsibility.
Thank you very much for your answer, Professor Zoltan Rimmer, and a couple more questions. The question
may I comment on this? This is a question by Afzal Javed, the president of the World Psychiatric Association. So it's a very important question to tackle, since as Ross previously said, the attitude is that even from the medical establishment is that this is not a medical problem. In order to answer such a question, one needs to see and analyze what the consequences of each acceptance would be and what it predicts. For example, if we accept a totally sociocultural origin, then African Americans in the US should have a higher suicidality rate in comparison to Anglo-Saxons. This is not the case. They don't even have any comparison of rates. They are very low in comparison to European Americans, which means that sociocultural factors play a very minor role in the baseline rates. The baseline rates, it's quite different from the changing rates when something happens, for example, an economic crisis. The baseline rates are not very much affected by sociocultural issues. For example, Hungary had similar suicidal rates during the Austro-Hungarian Empire, during the Soviet era, during the post-Soviet era, during the economic problems. In Hungary, no matter the situation, the political-economic situation, suicides were high. How about religion? Kazakhstan is Muslim, Egypt is Muslim. Kazakhstan is close to Russia in terms of rates, Egypt is close to Greece. Greece is Orthodox, Russia is Orthodox. No comparison of rates. Italy is Catholic, Poland is Catholic. There is no comparison of the rates. So religion per se, the type of religion, not religiosity, the type of religion does not seem to play a major role. So sociocultural issues do not seem to be a major issue concerning baseline characteristics, baseline rates. Now, the second thing we need to see is what kind of problem is that? It is a rare condition. In medicine, rare conditions are those who are very rare as events. They are below 1%. And suicidality, death by suicide, is 1 in 10,000 per year. It's a very rare condition. Now, very rare conditions are highly unlikely to be sociocultural and very rarely, very highly unlikely to be the result of something that it is easily manipulated and affects large masses of the population. The next thing is that the highest number of suicides is in males aged 30 to 55 or 60, something like that, which means that it's not a developmental thing because most of victims of suicide have matured. It's not genetic, hardly genetic, hardwired, but occurs when a more or less mature brain faces multiple challenges. And I forgot the last thing.
Very good comment.
What's the last thing? But all these characteristics of the problem of suicidality means that the last thing is that 90% of victims by autopsy suffer from a major mental disorder, either schizophrenia or depression. And rates of schizophrenia are similar across countries. Rates of depression might vary a little bit, but it's not 10 times more from country to country as suicidality is, which means that mental disorder is probably a prerequisite, but it's not sufficient as a condition to cause suicide. So there is something that adds on the presence of a mental disorder. This is why Hungary, which has similar depression rates in comparison to Greece, has higher suicidality. Something adds on that. On a more or less mature but problematic psychological function at the age of 40, let's say, in males, not really in females, very few females die. To cut a long story short, this is the story. This is a similar story of type 2 diabetes. Diabetes is something that evolves. It might be caused by behavioral, by food consumption. it changes the system of reacting to the environment, to glucose, and eventually causes structural damage. So it's basically biological, but it's a problematic response to challenges and insults of midlife.
Very good comment, and I should continue. You are right, Kostas. Professor Funtoulakis knows the Hungarian situation very well. You can see we have made a lot of papers. First, during the time of communism, as you have mentioned, 40, 30, 40, 50 years ago, the suicide rate of Hungary was the highest on the world, or among the three highest. But that time, when the suicide rate of Hungary was 46, the same rate in Poland, also the same communist bloc, 14. Bulgaria, the same time, 12. And the second biggest suicide rate on the world that time, 40 years ago, was in Denmark. The third suicide rate in the world was in Austria. And Belgium and Switzerland have shown also very high suicide rate, like by Serbia, Romania, Poland, as I have mentioned, and so have low. And it also supports that the view of Professor Funtoulakis that it was not an economical, not a political problem. Of course, economical, political problems can influence some aspects. Well, second, Hungarians living outside of the country. There are about 4 million Hungarians living outside, mainly in Romania, Slovakia, and so on, have the same suicide rate as in Hungary, and very different from the suicide rate of native Romanians, Serbians, Slovakians, and so on. And immigrants, Hungarian immigrants in United States and Australia have the same rate of suicide as in Hungary, and they are very different from the suicide rate of Australians and the Americans, and so on and so on. It also indicates a strong biological genetical factors. And Professor Funtoulakis is right when he mentioned that the depression prevalence is not very different, practically the same in Greece and in Hungary. But the bipolar disorder is very high in Hungary. The lifetime rate of bipolar 1 plus bipolar 2 disorder in Hungary is 5%. We published this in the Journal of Affective Disorder several years ago, and it can be also related to the very originally very high suicide rate of Hungary, because as we have seen, bipolar disorder carries much more higher risk of suicide than other form of depression. Very complex, very complex. And if at least I made that.
Zoltan, it's also the Finno-Altaic, the Finno-Hungarian hypothesis.
Yes, a Slovenian colleague, Marušić, Andrej Marušić, unfortunately died. A U-shaped curve from Baltic countries, from Ukraine, Hungary.
Based on the genetic map by Cavalli Sforza, published in 1994.
Yeah.
That exactly. There is a J starting from Finland and goes down to Hungary, a J of suicidality.
Absolutely. And the title of this paper in British Journal, Suicide Does Not Know Border. I just need to mention that I made an informal study looking at the position of notes in national anthems and suicide rates. Based on data, on suicide data on 1986, I have chosen 4 European countries. Hungary, suicide rate above 40. Greece, suicide rate 4. And 2 in middle, Austria, suicide rate 28. Poland, suicide rate 14. 46 Hungary, 28 Austria, 14 Poland, 4 Greece. And I counted the position of notes in the national anthems. And as I have expected, that the higher is the suicide rate, Hungary, the higher is the rate of deep notes. I published many years ago, and it's very interesting because, you know, Hungarian national anthem is very sad, and in comparison, Greek national anthem is like a march.
What
And
was
Italian
this?
also.
What was this song of the mid-war in Hungary, the Hungarian Rhapsody, that was linked to
Suicide. Gloomy Sunday.
Gloomy Sunday,
Gloomy
which
Sunday,
there is a similar song in Greek, Gloomy Sunday, but it's very, very joyful. Although the lyrics are very sad, the music is very joyful. The lyrics are essentially the same.
Mhm.
The lyrics say the same things, but the music is completely different.
Oh, yes, yes.
The Gloomy
And
Sunday.
my study on national anthems has been supported by the study of David Lester, who analyzed by computer. He published in Psychological Report several years ago that he really found, using a computer analysis, that the higher is the deep notes in national anthem, the higher is the suicide rate. It's very interesting because the composer of Hungarian national anthem also has bipolar II disorder. And the lyrics is the first verse, dear God, give good mood to the Hungarian. The Hungarian national anthems starts with these words, this God give good mood to the Hungarian, and a little bit later, this nation has been punished even for the future. The writer of this lyric of national anthems, he won on competition. Bipolar II disorder, very well documented bipolar II disorder. Creativity and bipolarity are strongly related. Yeah.
Next question, Daria, do we have any other questions?
Yes, we have. Thank you very much, Professor Kostas Fontolakis, for your valuable commentaries and interesting discussion with Professor Zoltan Rimmer. We have a couple more questions. One question from Dr. Senat Hasanagic. He asks, what is a relationship between suicidality and psychological, physical, sexual trauma at individual and populational level?
Yes, very good question. We have also investigated, but international literature published several papers about early childhood negative life events, abuse, child abuse, physical neglect, sexual abuse, and significant relationship between adulthood suicide and suicide attempt. And we have investigated the temperament of mood disorder patients who had early childhood abuse or not. And we have found, supporting the international literature, that mood disorder patients who made suicide attempts had significantly more frequent and significantly more severe irritable and cyclotimic temperament, which are suicide risk factors. And there are several studies, mainly from United States, showing that suicide attempters, even with mood disorder or without mood disorder, it is quite rare, of course, suicide attempters who had early childhood life events report significantly more aggressive features. Early negative life events can result in irritable or cyclothymic temperament can not result in it is too strong, but statistical association is true. And more aggressive, more impulsive features. And we know irritable temperament, cyclothymic temperament, aggressivity and impulsivity are strongly related to suicidal behavior. And this way, we think that this is a very complex but real problem. And if you look at that, the fact that bipolar and unipolar and alcoholic parents can create significantly more early negative life events or abuse than healthy parents. And this way, if somebody have a family history of psychiatric disorder, bipolar disorder, schizophrenia, and so on, alcoholism, drug addiction, that there are two very important factors: having a genetic predisposition, and because the psychiatric illness of the parents, this baby or this small child will suffer a lot of early negative life events, abuse. This is very, very dangerous combination, dangerous constellation.
Thank you very much. Thank you very much, Professor Zoltan Rimmer. And anonymous attendee asks, referring to the marriage as the protective factor to suicide, does the quality of it plays a role, or was it found independently?
Yes, it's very important question, because it is the problem of statistics. Statistically, marriage is a protective factor, and separation is also a provoking factor. But the quality of marriage is not the same, and a separation or divorce can be a resolution of a very conflictuous family situation. And if we could divide the marriage population into two parts or divorce, we could find a more strong association with good marriage and positive as a protective factor, and the provoking factor and conflictuous marriage or separation. And this way, I think this statistical association is valid, but in the majority of cases, marriage is a real protective factor, but in many cases, divorce or separation gives a resolution of the problem. And the situation is very interesting if you look at the widowhood. To become widow is also a special form of separation. And if not, you are the cause of the death of your parents, husband or wife, it is an independent factor. And widowhood is a very good so-called model in this respect, because it is not the same as separation because of 5 years long conflictuous marriage, and after after separation or divorce, or relative or my wife or the husband or the wife died by accident or the illness. It is very different.
Oh, thank you very much. So it's not so easy if you marry and move closer to equator, have a good partner or a relationship and so on. Not so easy. And one last question. Can aggression be the other side of depression? Recently in Greece, there is an increase in women's abuse and femicides or women killings. And can we blame depression for this phenomenon?
Yes, I think aggressive and impulsive personality features are very important psychological characteristics. And if somebody became depressed, this aggressive, impulsive personality feature became active and support the hypothesis or statement of Sigmund Freud that suicide is a clear auto-aggression when the aggression is directed for itself. And it's very interesting that looking at the criminal persons, aggressive persons who perform aggressive criminality have significantly higher rate of suicide attempt even before the first crime. It's very important. And non-white collar criminal, it is not true for them. Only aggressive criminals have much more positive family history of suicide and much more, much higher rate of suicide attempts even before the first criminal act. It's very important. But because after it depends on several other factors, but before that, it's victimology.
Daria, may I make a clarification on the previous question?
Thank you very much.
It was mentioned that there is an increase in violence against women and femicides in Greece recently. This is the prevailing picture in the media and the social media, but we don't know whether it is really true. What we do know is that for the last 20 years, we have approximately, give or take, 150 deaths by homicide. 100 are males and 50 are female victims. And half of these 50 are what we say, we used to say passion crimes, and now we call them femicide. It does not seem there is an increasing trend. On average, there are 20 to 25 per year of these deaths. And the year 2020, if I am correct, at least Meropi Zoufi, a member of the parliament, last week said that last year we had 17 such deaths, which means that there was not an increase. Now, the Elstat, the official statistics, will come out in 1 or 2 years. So until then, we don't know, but there is not an evidence-based picture that there is any increase. The media, of course, focus on this, but we don't really know. And as for domestic violence, this is what we don't know, and we will never know the real picture. To add to what Zoltan said, in countries like Mexico, where homicides are at the highest, you don't see any correlation between homicides and suicides because there is a ceiling effect. In Europe, you see a strong correlation and they go together. Homicides and suicides go together usually. In Asia, there is an intermediate situation because there are countries with high homicidality, and it's a more complex. And also in Africa, there are no data in Africa for Africa. But in Europe, there is a strong correlation, as Zoltan said. But in countries, especially in the Americas, there is no correlation because homicide rates have a ceiling effect. So there is no statistical power there. But the old psychoanalytical argument that you either kill or die, it's not. You do both. You do both.
Thank you very much. So this is all about the questions from the audience. Thank you very much for interesting discussion. Thank you to our amazing speakers, Professor Rosalba Cervini, Professor Zoltan Riemer, to Professor Afzal Javed and Professor Peter Morozov for the WPA support, and to our mentor and main organizer of the MIDI expert webinars, Professor Konstantinos Fontolakis. Thank you very much to the co-moderator, Professor Eva Maria Tsopakis and Georgos from Let's Study Greece for amazing moderation of each of the webinars. Thank you very much, and have a nice day, life till 100.
Thank you, Daria.
Bye bye. Take care.
Thank you.
Bye-bye.
Thank you. Bye
Bye-bye.
bye. Bye.